Really takes the skills of the clinicians on the front line and puts them in the place where they can be most effective.
We've stopped people going into hospital, we've helped people remain independent in their own homes. That has been fantastic.
This has been wonderful. My cases are being seen by the appropriate people in a quicker fashion.
When patients see an NHS sign over a door, they see NHS. They don't care if it was the GP surgery with the NHS sign or if it's social care or if it's community nursing. They see NHS, so they expect the NHS to help them in their time of need. The idea of INT is to take a more collective approach. So what we do is we share intelligence on the patient, and so the continuity from an INT model will be massively improved over the previous way we were working.
I'm extremely proud. I was involved in the project from the get-go, where we had a hothouse event bringing people together from across health, social care, voluntary sector, primary care, acute sector and community services to try and solve a wicked problem in our system, which is about how do we join up care for frail elderly people. We were challenged with setting the project up from an idea, a concept, in 90 days, getting it up and running and making it happen, and we delivered that. So I think that's a real testament to the people that have been involved in the project and their passion to do the right thing for patients.
We've got things moving a lot quicker, we've stopped people going into hospital, we've helped people remain independent in their own homes. It's putting their voice forward and putting their voice first and listening to that person.
I was in and out of hospital, and every time I came out I was moved to someplace else, and I was getting really depressed, and Pat and Angela worked hard to get me here. I'm really settled now, you know, I'm really happy and content.
I think Grace is a fairly good example of how INT can really help patients. Grace had a complex set of problems that couldn't just be fixed by me alone. I can sort her medical problems out, I can sort her prescriptions out, but it wouldn't be enough to have resolved her situation in terms of housing, in terms of placement, in terms of the things that were affecting Grace and what would ultimately allow her to be happy.
I've known Grace for over a year. We had this problem of inappropriate home environment, then hospital admissions. I then had a meeting at the Integrated Neighbourhood team and brought Grace's case forward. It was agreed a social worker from the INT would do a joint visit with me to review Grace. So that was Pat, and Pat completely understood what I was putting forward and what Grace was putting forward. And I don't think I would have got the same response if I'd done a general referral to the social care team.
Okay, if I check your oxygen levels?
I think through discussion with different disciplines, joint working with Angela the matron, we've both got to know Grace very well. Grace has got to trust us to help her come to the point in her life where she's happier than she's ever been before.
That's lovely, thank you.
I mean, Angela and Pat, I consider them as friends. Well, they're great together. Took me out of the doldrums. I'm not depressed anymore. I'm quite happy and content here, you know.
Traditionally what's happened is that people are managed in silo. So they'll come and see me, I'll do the GP bit. They have a social care need, so the social worker will come and do a separate assessment and go through their own criteria. Lots of people doing lots of good work, but separately.
Probably would have had a social worker, they would have had visits from their GP, visits from the community matron, district nurse, possibly some voluntary organisations. What the INT is doing is joining that all up. They'll have a lead care coordinator. They liaise with the other members of the Integrated Neighbourhood team, so that means that other members of the team don't necessarily all have to go and see them separately.
Hospital needs to be made aware.
So actually, ultimately, I think the workload for those health and social professionals should go down as we work through the INT.
Part of the reason why it's a neighbourhood team is trying to use the facilities and services we already have in the community to help support people. Seeing your GP, most people would see that as first line, What we're saying in INT is no, there's actually things out there in the community that can help people maintain their independence, be happy and be well without even seeing a doctor.
In my experience, it's not so much the health concerns, it's the social and psychological problems that then impact on the health. The INT has helped me because I've been able to get the multidisciplinary team face to face. That's helped me then get patients and persons and families services that they need.
I think everybody who works in the public sector these days is very conscious of trying to make the best use of the resources that we've got. So it was about hearts and minds of the staff that really wanted to get this done because it was the right thing to do, as opposed to it trying to prove it was the cheapest or quickest thing to do. And if it does that as well, then that's great.
If you can maintain somebody in their own environment, the environment that they want to be in, and independently a lot of the time, we're not escalating into residential or nursing homes. It's very much a preventative model in the fact that we are preventing them becoming more dependent on other services.
I believe it's really worked for the patients because they've been able to get quicker decisions and more joined up care and care that's centred on their needs. I think it's also very satisfying for the staff when they talk about actually being able to deliver care for patients seamlessly, which is what we say very often in NHS and social care, but it's a really difficult thing to do.
These are not junior resources, these are quite senior resources that we're putting around the table, but to the benefit of patients. And when you talk to the team, no one's talking like a GP or a social worker. It's what's going on with this patient, why is it going on, and what are our options to help the patient.
So initially the INT was aimed at looking at patients over the age of 75 with a number of long-term conditions or medical and social issues. What the pilot has told us is that actually there are a lot more patients out there under the age of 75 that could use the services of the INT. So we have lowered the age limit down to 65. For the scale up, we could potentially be looking at patients over the age of 50 if we think that the INT service can provide them with the support that they need.
I believe it's the right thing to do for patients, and I think it's a model that we should take now and roll out across the city, and also I think we should champion far and wide because I think it's a really, really super development.